Good afternoon and welcome to today's Grand Rounds presentation. Please remember to sign the attendance record so that you get credit for being here. And also please remember to fill out the program evaluation, and if you could give us any ideas in regards to future topics and future speakers, that helps out the CME committee and gives us some ideas to what your areas of interest and educational needs are. Today it's my pleasure to introduce a speaker from the University of Iowa. And our speaker is Dr. Rami Abiad. Dr. Abiad is a gastroenterologist. He did all of his training at the University of Iowa, and currently he's a clinical assistant professor of medicine at the University of Iowa. And here he's here to discuss GI bleeding, diagnosis, and treatment. And please join me in welcoming Dr. Abiad.
Hi, good afternoon. Tell me if you hear me okay up there. I apologize for the accent. I'm imported from Lebanon. Thanks for the invitation, and please feel free to interrupt anytime you have a question. I'll be happy to answer it. The talk is a little bit long. I'll try to go through it within the allotted time. There's some videos, and I'll explain to you stuff as the videos come along. Let's get started. So thank you for inviting me again, and if you're here for the wrong reason, I've got my G.I. Joe. You can get it. I have nothing to disclose. The objectives of the talk are going to be about GI bleed. Mostly I'm going to be talking about acute, overt GI bleeding, but I'm going to address some other causes of GI bleed and the way we manage them and what tools we have to help us with that, and then a short conclusion in that regards. As you can see, this is a great topic. I'm going to be a little bit specific, and in no way this talk is comprehensive. So this is a small video capsule about a patient who got admitted around almost a year ago. The patient came in with melena, and upper endoscopy was negative, colonoscopy was negative, and then he was transferred to us for further evaluation. The video capsule, as you see, showed blood within the proximal small bowel. Now I'm going to define GI bleed. Defining GI bleed makes it helpful for us to address it, and limits, in a way, the differential diagnosis. So overt is a sophisticated word for visible. It presents as hematemesis, vomiting blood, melena, passage of black stools, maroon stools, it's like wine color, and hematochezia, blood per rectum. Occult, it's no visible blood. It's subacute bleeding. Most commonly, patient presents with positive fecal occult blood test or iron deficiency anemia. And obscure, which can be either overt or occult, it's not obvious. It's GI bleed that persists or recurs with no etiology found on endoscopic and radiologic evaluation. So certain things to know. Blood is cathartic, so if somebody bleeds, it's going to come out. You're going to see it. It's not afraid, blood is not afraid to show itself. And it takes around 50 cc's of blood to turn your stools black. So having melena does not necessarily mean lots of blood coming down. However, if you have a lot, more than 4 cups, you're going to see red blood, and that's going to cause rapid transit. Some patients come to us and tell us, well, hey, doc, I have lots of bleeding. And you ask them, why do you think that? It's like, I was having a bowel movement and the toilet turned all red. Just for your own knowledge, 5 cc's of blood are enough to turn the toilet bright red. Blood in the intestine for more than 14 hours can turn into melena. So if you have a small angiectasia in the cecum and it stays there for some time, it can present as melena. The bacteria in the small intestine or the large intestine can cause oxidation of the iron into hemochromes, and those are black. Patients who have a GI bleed, they can have output of blood up to 5 days after the bleed. So if you have a patient who was admitted to the hospital, was managed for GI bleed, and he becomes hemodynamically stable and continues to be that way, but you notice that he's outputting melena, that does not mean he's having active bleeding at the time. It also takes around 3 days for the H&H to equilibrate. So meaning if the same patient, if he's in the unit, he looks stable, vital signs are okay, he's not tachycardic, he's still having melena, and his hemoglobin is slowly dropping, he might as well have stopped bleeding. So it does not mean he has active bleeding. Now, having said that, if you see red blood meaning means active blood, active bleeding. So normal people have 1.5 cc of blood loss per day. That's normal. The fecal occult blood test becomes positive if the blood loss is 2 cc's or more. Now, having said that, melena, you do not need to test the fecal occult blood for that because it's visible, okay? And from the studies that we have, there's no role for fecal occult blood testing beyond the clinical context of colorectal cancer screening. Now, some people use it in patients with anemia and obscure bleeds, especially coming with iron deficiency anemia, and that's debatable. Now, other definitions of GI bleed, acute, less than 3 days, chronic, usually presents with anemia, massive GI bleed, and that comes in, the way we define it is shock, orthostatic hypertension, 6% drop in hematocrit, or requiring 2 units of packed RBC transfusion, or you see that the patient is actively bleeding. Now, we also try to classify GI bleeds into upper and lower GI bleeds. Upper GI bleed classically has been defined as bleeding proximal to the ligament of Treitz. Now, I put in italics above the ampulla of Vater. And the reason why I did that, because now there's a recent advocation for different classification about mid-GI bleed. Now that we have balloon-assisted enteroscopy and capsule enteroscopy, we can evaluate the middle GI. So if you want to think about it, upper GI bleed is a GI bleed proximal to the ampulla and is evaluated with an upper endoscopy, so within the reach of the EGD. Usually patients present with hematemesis, coffee ground, bloody emesis, or melena. And further subclassification of this, because it depends on management, prognosis, and the like, is whether this is variceal or non-variceal. Now, mind you, some people tell you we vomited blood or we put out blood, and they mean hemoptysis. So you just try to distinguish whether they coughed out blood. Some patients are anticoagulated, they're over-anticoagulated, and they have nosebleeds, they go to bed, it pools in the back of the throat, they swallow it, wake up in the morning, vomit blood. So keep it in the back of your minds. Hematemesis suggests ongoing moderate to severe bleeding from the esophagus, stomach, or duodenum. So something that happens in the proximal GI tract, refluxes back into the stomach through the pylorus, and then patient vomits it. Coffee ground emesis, it may be intermittent, it's maybe have stopped, and it's a limited GI bleed. So lower GI bleed, it's most commonly colonic bleeding evaluated by colonoscopy. It's usually beyond the ileocecal valve, so from the cecum distally. Patients usually present with hematochezia, maroon stools, bright red blood per rectum, and sometimes, or up to 15% of patients presenting with hematochezia have an upper GI source. And that's why when patients come to the unit and have red blood per rectum, we consider doing an upper endoscopy on them for this particular reason. Melena, black, tarry, foul-smelling stools. So nurses know how melena smells. Hematochezia, it suggests active bleeding with either from the upper GI tract with the rapid transit, or small bowel bleeding, or distal colonic / anorectal. Now this is the entity I was telling you about, the mid-GI bleed. With the introduction of the balloon-assisted enteroscopy and video capsule endoscopy, the small bowel could be evaluated beyond radiologic and barium studies. So it's defined as small bowel bleeding from the ampulla to the ileocecal valve. Now, mind you, some people confuse obscure GI bleed with mid-GI bleed, and it's not the case. So things to know when it comes to GI bleed, we want to know how much the patients are bleeding, where the bleeding is, and how fast. And the rule of thumb, the closer the bleeding is to the anus, the bright red the blood will be. Exception, massive upper GI bleed or slow lower GI bleed. This is my favorite slide. All right, so why do we care? One, because it makes a difference to the patients. So 2 to 15% of patients do die from GI bleeding. Patients get hospitalized around 1 million annually in the US because of GI bleed. And depending on the site of the GI bleed, it costs $9,000 to $40,000 a pop every admission. So that's billions of dollars spent on GI bleed. So the goal of management, resuscitation, medical intervention, I'll talk about that. Clinical diagnosis and treatment, I'll talk about that. Diagnostic and therapeutic endoscopy, I'll talk about that. Risk stratification and triage, I'll mention some shortly. Do you have any questions? Am I talking too fast? Can I go faster? All right, this is the case for you. So 54 female with several episodes of melena over the past 3 days. Blood pressure, mid-90s, systolic with a heart rate of 110. What's the most important next step in managing the patient? NG intubation and lavage, IV PPI and octreotide, IV access, fluids and blood product transfusion, IV erythromycin followed by EGD. See, great. So don't lose the whole picture. Just because somebody's bleeding does not mean they need to be scoped immediately. So the fundamental principles of resuscitation and management of acute GI bleeds are the same regardless of the origin of bleeding. So don't forget your alphabet. ABCs, airway, breathing initially. See if the patients need to be intubated. So those are the patients that are at higher risk of complications. So if somebody presents with altered mental status, it's obvious, massive upper GI bleeds. So those patients need to be intubated so that we have secure airways when we want to scope them. Circulation, 2 large bore needles, maybe central line if they need that. Get your labs while you're doing this. Volume replacement with fluids, depending whether you're a surgeon or internist, so normal saline or lactated ringer. Transfusion of blood products, depending on the clinical scenario. Give blood, platelets, hold and reverse anticoagulation. See if you want to give vitamin K or FFP. Stop antiplatelet therapy. And correction goal should be systolic, the hundreds, pulse less than 100, hematocrit 24, hemoglobin 8, INR less than 1.5, and platelets greater than 50. Do not over-resuscitate. Patients with esophageal varices, when there's increased pressure, the varices can bleed again. So do not be overzealous. I tell my fellows the enemy of good is better. So that's why. At presentation, you want to risk stratify your patients. You want to see if those patients are good to go home from the emergency room. And I know not much of us do it here, especially in the US, because of litigation. Whether the patient needs to go to the floor, safe to go floor, telemetry, or they even need to go to the intensive care unit. So check for shock or orthostatic changes. A quick look at the mucosal membrane, see if they're dry. Check their JVD. Put a Foley in, see the urinary output. And don't be afraid to consult. So consult GI, consult surgery if need be. This is just a general thing. So if you lose 20-25% of your blood, so around 2 liters, you're going to present with shock. Sorry, this slide, you won't see anything from it. If you get something, it's just the reference here. These are the risk stratification scores that they did in the past. So there's Baylor, there's Cedars-Sinai, there's Rectal score, Blatchford, and Ames 65. I thought you'd like this, Ames 65. So for Ames, I think it's easy to remember. So we're looking for, it's the acronym for albumin, INR, mental status, and systolic blood pressure, and age 65. So it's easy to remember. And each one of these factors are given a grade of 1. So if you have 1 or less, they're low risk. If greater than 2, they're high risk of mortality. Albumin, the number is 3. If it's less than 3, that means underlying liver disease. INR 1.5. Mental status, they say, well, high, greater than 14, I think. And systolic less than 100. Focused history, I know you don't have enough time for that when you're in the emergency room and trying to resuscitate the patient, but some of them are really quick to ask, either from the patient or from his immediate family or companion. So older patients, you're going to look at the name before seeing them, so you're going to see that. Onset of bleeding, when did it happen? If the patient had prior history of bleeding, if they had childhood bleeding or bleeding during childhood, you want to think about congenital stuff, or platelet disorder, or bleeding diathesis, comorbid conditions. Any failure that you see on a patient is a high risk. So heart failure, renal failure, liver failure, cancer failure. So anything that has a failure next to it is a high risk. Prior abdominal surgeries, and it's really important. It's very easy to look at. Just lift the patient's shirt. Make sure you have a chaperone if the patient is a female. If there's a AAA repair with a prostatic graft, you want to think about aortoenteric fistula. This is really important because you can save a patient's life if that's the case. Prior history of radiation for any particular reason, GYN cancers or GU cancers. History of polyps, if patients had previous polyps, Peutz-Jeghers syndrome. History of cancer of any form, prior surgeries, history of polyposis in the family or bleeding diathesis, recent intervention. If the patient had a colonoscopy recently within the 10 days, 2 weeks, that's the window for post-polypectomy bleed after the eschar from coarterization has fallen off. Prior surgery, if the patient has anastomosis, the problem would be at the anastomotic site, maybe previous trauma, associated or preceding symptoms. Let's say patients have been having pain and bloody diarrhea for some time. If they lost some weight, you want to think about malignancy. You want to think about ischemic changes. Ask about antiplatelet, anticoagulation use. Some medications can interfere with anticoagulants, as does some herbals. And ask about substance abuse, including alcohol and drugs. Quick physical examination in addition to the vital signs, mental status. If the patient's talking to you, is okay. If it doesn't make sense, looks intoxicated, then you want to think about intubating them. Lift the shirt and look for surgical scars. Feel for abdominal masses, bruise, tenderness, any stigmata of liver disease. Just quick look. Icterus, ascites, splenomegaly. And dermatologic examination is quick and easy. So looking at the lips, you can see pigmentation if you want in patients with Peutz-Jeghers syndrome, or you can see some telangiectatic changes of Osler-Weber-Rendu. Look at the buccal mucosa, at the skin. You can see changes of liver disease, patients who have like acanthosis nigricans, maybe have internal malignancy. And then you can drop in an NG real quick and lavage it. A positive NG lavage is very helpful. Negative happens in 16%, doesn't help much. And yes, please, everybody hates this part. Rectal examination is very important. It's either there's blood or not. It's very easy. Black, you can tell. And this is a hint for you. So this is normal for most people. Brown. In the middle is blood. The last one is tarry. And the thing on this guy's hand is tar. It's not poop. Usually melena is black, sticky, and foul smelling. So once you've smelled it once, you know what I'm talking about. Neither clear NG aspirate or the absence of bile without blood rules out an upper GI bleed. So only if it's a positive test, it's helpful. If it's negative, not much. You might be missing something. And please don't do occult testing. So it's just a quick rectal examination. If the patient had the bowel movement, you can take a quick look at it and it'll show you. Labs, CBC is important. Usually these patients have elevated white count. And in the most part, if it's an acute bleed, the MCV should be normal. If they have low MCV and they don't have thalassemia or other blood disorders, it means chronic bleeding. E2, usually BUN is elevated due to digestion and blood and absorption of urea. LFTs is the function tests. I'm talking about bilirubin, albumin, and DNR. And those tell you the underlying function of the liver and helps in prognostication. Type and cross. H. pylori, you can keep the tube just for later, just in case he has a duodenal ulcer related to H. pylori. If patients complaining of chest pain, obtain cardiac enzymes. And remember, we bleed whole blood. So even if you have normal blood and you're convinced that the patient is bleeding, the patient is bleeding. So normal blood does not rule out a GI bleed. And presenting hematocrit may be significantly underestimated, underestimating the amount of blood that the patient has lost. So check serial H&H. You can do it 4 or 6 hours. And remember, I mentioned it before, it takes around 3 days for the intravascular and the extravascular volumes to come in equilibrium. Other studies, if you're thinking somebody who had the previous aortic graft, get a CT scan to rule out aortoenteric fistula. If somebody has pulmonary symptoms or you think is aspirated or is having chest pain, think about chest x-ray, EKG, and you can get an abdominal x-ray to rule out, let's say, valvulus and causing ischemic problems. But whatever you do, just avoid barium studies. The reason why we do that is in case the patient is going to require angiography and the guy's abdomen is full of oral contrast, the radiologist won't like you. Now, everybody is familiar with these medications. When somebody comes in with a GI bleed, it's a reflux. Let's start PPI, octreotide, resuscitate, give him fluids, blood products, and call GI. So PPI, just as a general rule, PPI in peptic ulcer disease is helpful. Not much in variceal bleed. The other way around, octreotide is helpful in variceal bleed, but not in peptic ulcer disease. You can argue with me and we can talk, but this is the gist of it. In the past, the octreotide was used for splanchnic vasoconstriction, and it can reduce the blood flow to the GI tract and maybe reduce bleeding, but overall, it's not cost effective. So pH of greater than 6 stabilizes the clot, and you want it to stay steady that way. That's why you want to put the patient on IV PPI rather than continuous IV, rather than boluses or given H2 blockers. Although it improves the signs of bleeding seen on endoscopy, it does not change outcome, whether the patient would require more blood, whether the patient is going to rebleed again, or whether the patient is going to die. Giving PPI is not going to change that. Octreotide causes splenic vasoconstriction, and this is used for variceal bleed, whether it's a esophageal bleed or gastric bleed, and it decreases the rebleed rate. There's no adjunct benefit in non-variceal bleed. Prokinetics, we like it because it helps empty the stomach from the gunk that's in it. Usually we give erythromycin, but it takes forever to get it from pharmacy, so Reglan is good enough. It decreases EGD time and reduces the need for a second look endoscopy. Some people in the past used to give iced saline because they thought it caused vasoconstriction. We're saying NG lavage, not IV. But this may impair coagulation and cause hypothermia. So using tap water is good enough. You don't have to use sterile water. And if patients are cirrhotic, give them third-generation cephalosporin because it decreases rebleed rate and mortality. So after proper medical resuscitation, endoscopy should be performed. If you're suspecting that the patient is having something serious, and I'm talking about aortoenteric fistula, that's the one common thing or one main thing that would bring the gastroenterologist out of bed in the middle of the night. And that's what I stress on my fellows to ask or to figure out whether the patient had a previous aortic surgery. If the patient has rebled, if the patient is in intensive care unit, if you think that the patient has variceal bleed, you might want to do it sooner than 24 hours. So the endoscopy is good enough in 95% of the cases in finding the bleeding source and intervening. And usually it's also helpful in risk stratification once we find what the bleeding cause is. It doesn't come without a cost. The cost is aspiration, perforation, and maybe messing around down there causes more bleeding. And once the patient is stabilized, we reevaluate and see what needs to be done. If the patient rebleeds, we have to consider rescoping them. If we think that something has been missed or there's more we can do. If not, then we can ask our radiology friends to help us obtain a tagged RBC scan, which is good in showing where the bleeding is or the approximate area of it, because it's sensitive up to 0.1 cc per minute. Angiography needs a greater rate of bleeding. You can do a balloon tamponade with a Minnesota tube or a Sangsteak and Blakemore. Get a surgery consult if you think that the bleeder is in the posterior duodenal wall, duodenal bulb, or it's high in the lesser curvature. Those are sites of two major arteries, the gastroduodenal and the left gastric. So they might be of a larger caliber, and even us gastroenterologists, we cannot stop it. If we think it's a mid-bowel bleed, consider video capsule endoscopy or balloon-assisted enteroscopy. I'm talking about single balloon, double balloon, Spirus, Naviade, you name it. Imaging studies might be helpful if you're considering a mass. I had a patient with neurofibromatosis, came in with GI bleed, upper endoscopy, colonoscopy negative, video capsule, so bleeding within 30 minutes. CT scan showed a mass down there, double balloon revealed gist in the small bowel. And then long-term plan, what do we need to do for this patient? Does he have H. pylori that needs to be eradicated? Is this patient cirrhotic, needs to be on beta blockade, and has to come back for repeat endoscopy for variceal obliteration? Whether the patient needs to follow up with subspecialty, is it a bleeding diathesis and he needs to see hematology? Any questions? Am I going too fast? All right. All right, so etiology of GI bleed, I have this in your handout, so I'm going to skim through it real quick. I'll show you the images with it if you want to follow through with this. Those images are contribution from people I've worked with, from an atlas that I have. So esophagus, severe reflux esophagitis can cause bleeding. Pill esophagitis, Mallory-Weiss tear, consider that in patients who are pregnant or alcoholics. Candida esophagitis, Rarely presents with GI bleed, but it's commonly seen. Cancer, you can see that. Foreign body ingestion, if it stayed there and causes pressure ulceration. Radiation esophagitis, if somebody had any chest radiation for one reason or another, lung cancer, lymphoma. NG trauma, usually a patient is in the intensive care unit and NG was pushed in and they get a positive NG output of blood. Caustic ingestion accidentally or in suicidal attempt, you can see that. Lymphoma, patients who had transplant before, CMV, esophagitis, and patients who are immunosuppressed for one reason or another. Strauss ulcer, usually patients in the unit, intubated on ventilation, burn patients. Gastric erosions usually come in with anemia or positive fecal occult blood. GAVE, we see it very commonly in patients with renal failure, liver failure, cardiovascular disease, or with advanced age. Delafoy lesion, this is the elusive lesion. Large caliber vessels that open closer to the mucosa. They can bleed like crazy and then disappear. Angiodysplasias, they look like spider webs. Those are perfusion dependent. So if somebody is hypotensive and even if the lesion is there, we might miss it because it's not being perfused. Cameroon lesions, these occur in patients with hiatal hernia. It's ischemic changes as the stomach goes in and out within the hiatal sac, within diaphragmatic hiatus. Gastric lesions, CMV ulcer, NSAID ulcer is very common. GIST, gastrointestinal stromal tumor, they can come ulcerated like that. Cancer, gastric ischemia is rare, but you can see it in the setting of volvulus or post-op. Also Weber-Rondeau, those patients have these distinctive telangiectasias within the GI tract. Duodenal ulcer, suture ulcer from previous surgeries, ZE syndrome. And those patients are hypergastronemic. They produce lots of acid, and usually the problem is not in the stomach because of increased acid, because the stomach is used to seeing acid. It's usually in the esophagus and the small bowel. Crohn's disease, ischemia, varices, you can see them throughout the GI tract. Duodenal cancer, CMV, Roux-en-Y ulceration. This is aortoenteric fistula. Sometimes you just see a clot, sometimes you see some oozing, sometimes you see blood. The CT scan shows loss of plane, sometimes bleeding. Sometimes on endoscopy, we give lots of air, and then we see these corkscrew in the end. It's like, oh, that's the cause of the bleeding. But no, that's a barotrauma. Post-polypectomy bleed, it can occur immediately, and we recognize it endoscopically, or it can occur within 10 to 14 days when the eschar falls off. Hemophilia, considered in patients who had PTC or liver biopsy. You see blood coming from the ampulla. Portal hypertensive changes, these are esophageal varices. This is the nipple sign. It's fibrin clot. Portal hypertensive changes, this is a description of snakeskin appearance or mosaic pattern. These are the varices after them being banded. These are gastric varices, look like grapes. And this is post-band ligation and necrosis of the area. These are the grading of esophageal varices. You see them on the side, F1, F2, F3. I'll have you read this from the slide. Now, with peptic ulcer disease, that's what we talk about stigmata of bleeding. So we try to classify bleeding ulcers based on what we see endoscopically. So there's spurting vessel, non-bleeding visible vessel, adhering clot, oozing vessel, pigmented flat spot, and clean base. And I'll tell you why we need to do that in a second. We notice the shades, the 4 are red and 2 are yellow. And those 2 yellow things are the patients who, if you scope in the emergency room, you can send home on PPI. So these are safe to go home. And that's why we need to know If patients are actively bleeding on endoscopy, they have 90% chance of free bleeding, visible vessel 50%, adherent clot 33%, oozing up to 27%. And the other two I was telling you about, the flat spot and clean and ulcer base, they're very low. And if they're very reliable or have family member with them, you can send them home. Now, etiology of lower GI bleed is also within your handout. Most commonly is diverticulosis. It's like Swiss cheese. And you see how thin it is where the vessels come, where the herniation occurs. Crohn's disease, ulcerative colitis, inflammatory polyp, usually ulcerated surface, cancer, angiodysplasia, ischemic colitis, patients who are vasculopath, or patients who had recent surgery or intensive care unit, radiation proctitis, GYN or GU cancers, usually cervical cancers in females and prostate cancer in males, C. diff colitis, and that's why we ask patients about antibiotic use, CMV colitis if they're immunocompromised, anastomotic varices, previous surgeries, blue rubber blood nevus syndrome. I've seen one of those, and although it makes people very anxious, you can actually snare this off. NSAID ulcer, anorectal disease. These are hemorrhoids, internal and external, and anal fissure. Anal fissure is painful, so you can ask patients if they were constipated, had a big bowel movement, and they started bleeding. Usually, if it's a vet, this is the first thing he tells you. Now, middle GI bleed is also within your handout, so you can go through it. I'll show you some images from a given capsule atlas. So there's bleeding, active bleeding, and I showed you the clip in the beginning. NSAID enteropathy, small bowel lymphoma, Crohn's disease, and here you can see the actual graft from the AE fistula, radiation enteritis, suture ulcer. You can see the suture, carcinoid. These are a little bit elusive. Also, jejunal cancer, metastatic melanoma, angiectasias, Meckel's diverticulum, blue rubber blood nevus syndrome, Whipple's disease, GIST, and varices. Any questions? All right. So do we really need to do anything? I mean, 80% of bleeding stops eventually. And that's what I tell my fellows. I mean, bleeding eventually stops. I mean, some people die and it stops, but for the most part, it stops without patient dying. But of those who continue to bleed, 1/3 of them die. So we have to do something to help them. And that's when we pull the finger. What's the goal of endotherapy? Control bleeding, minimize bleeding rate, reduce the risk of free bleeding, and improve outcome. There are lots of things we can do. This is not one of them. We can help patients. Hemostatic devices, there's injection, so injection needles, mechanical, eclipse, band ligation, detachable snares, thermal therapy, and cryotherapy. Which one to use? It depends what you have. You can't use something you don't have. What the local expertise is, what the indications are. For varices, esophageal varices, you ban. If it's a peptic ulcer, you inject and clip or burn. And I'll talk about them in a minute. What the comorbid conditions are. So if somebody has coagulopathy and it's uncorrected, if you burn the guy or if you inject, you're going to cause more bleeding. So you're better off maybe placing metallic clips on them. Feasibility, characteristic of the lesion. If the lesion is too big, the blood vessel is large, or if the area is fibrotic, you can't apply a clip. And what the cost is. So it's good to have nice toys. Unfortunately, we do. This is, we call it the Buster scope. It's Olympus XTQ160. I'm not advertising Olympus, but we have this, and the diameter of the scope is 6 millimeters, so it's pretty large. It facilitates clearing of blood clots. It has pedal-activated water wash, and look what it does. So this video is courtesy of Dr. Henning Gerke. He's my teacher and my colleague now. So you cannot visualize the proximal stomach, so the fundus, cardia are not visualized. And this is with a buster scope. And look what we're missing. See the bleeder? Here you go. All right. So injection needles, they come in different sizes. We can inject different kind of solutions, and I'll show you what we can inject. The most commonly used one is epinephrine. It comes in different dilutions, but the most commonly used one is 1 in 10,000. You can inject it around the bleeding site, and the way it does that is tamponading, so applies pressure on it, plus the epinephrine can cause vasoconstriction and activate the platelets. You want to use it with caution in cardiovascular disease, but it has been shown that it's safe in lots of cc's, 25. Sclerosing agents, absolute alcohol, sodium morowate, pilodocanol, adhesive agents. We use those in patients with gastric varices, fibrin glue, or even hypertonic dextrose. They cause vascular thrombosis and tissue necrosis, which eventually heals with fibrosis. And indication is mostly variceal bleed. So if it's in the esophagus and these patients have failed variceal band ligation, we inject this sclerosing agent, but they can have risk of strictures. The glue can have risk of embolization and sepsis. These are the agents and how much we can use. You have it on your side and your handout. And these are fundic varices. Patient with cirrhosis came in with GI bleed. Local endoscopist saw gastric varices, was transferred to our facility. And there are two agents that we can available in the U.S., Dermabond or histoacryl glue. They're sterile super glue, so gives everybody has. If they use them, you probably had some on your hand, gives this effect, and it forms a clot at the area. So what we do is we prime the needle, we put in a mix of, I'm going to call it glue with radio opaque oil, and then we inject it in the site. And then once we've injected 1 to 2 cc's at a time, we pull out the needle and inject on the top of the, where we put the needle, and that seals it. And then we probe again and see how hard it is. If it's still soft, we inject more. So here it's soft, and here's soft. So we inject more. And then until the probing feels that this lesion is hard enough, that means the clot has been formed. And then the patient is good. Here's a little bit soft, the other end is hard. These are soft varices. This is not FDA approved, so you have to get a special consent from the patient or the family. If we know beforehand that this patient is coming with this, we can send the patient A big chunk of the time, the patients are intubated, so we get it from the family. Sometimes they come as outpatient, and we get this done. It's used throughout outside the United States, but it's not FDA approved for this purpose. Alternatives include the TIPS. This is 6 months after the gluing. Usually the stomach extrudes the glue clot. And thermal devices, we generate heat, causes edema, protein coagulation, contraction of vessels, and activation of the coagulation cascade that eventually generates the hemostatic bond. Thermal effects, it depends on the intensity and the duration. Complications include deep coagulation and perforation. Usually we try to treat vessels less than 3 millimeters in size. So heated probes, you have those in the handout. You can just take a quick look at them. And I left the bipolar probe size and settings for each indication. That might be helpful for gastroenterologists. The other thermal device is a non-contact thermal device. It's argon gas. We activate the ionized argon and target it towards the tissue, and that causes desiccation and eventually coagulation of the tissue. And once the tissue is desiccated, it becomes non-conductive. So it's pretty safe if the probe is not touching the actual mucosa. Indication usually vascular lesions, so AVMs, angiectasias. We do it for GAVE, radiation-induced changes. And this is how it works. This is the angiectasia, and then it causes this like thunder, lightning, sorry. These are the ulcer stigmata, and what do we use for treatment? I showed you the 6 kind of thing: bleeding vessel, clean base, oozing, all those kind of things, and what the rebleeding rate is, and what the modality of the treatments are. And those are the 2 ones that I told you we can send straight from the ER because they don't require endoscopic treatment. We went in, they have a clean base ulcer, we put them on a PPI, check H. pylori, stop NSAID, send them home. The other stuff, the adherent clot, non-bleeding visible vessel, and active bleed, they require dual therapy, meaning injection treatment and either burning or clip placement. Cryotherapy, it's not available at the university for GI lab, but it's available in pulmonary. But you can also freeze the abnormal blood vessels. It's usually for angiectasias. Mechanical hemostasis, these are different kind of clips. They come in different sizes. Some of them are rotatable, some of them are not. Some of them you can open and close. Some of them, once you close, you cannot open. And each from a different kind of industry. These are the lesions that we're able to do clipping on, accessible lesions, pliable, small blood vessel, and less than 3 centimeter defect. The others become more technically challenging. This is how it works. So this is after endoscopic mucosa resection of a lesion. We removed the polypoid lesion from the esophagus. This is courtesy of Henning Gerke again. And then we cause post-EMR bleed. This is a clip, resolution clip, where you suck on the tissue and then boom, you can approximate it together. Band ligation, we have a tip that's mounted on top of the endoscope. We suck the tissue into it, and then we apply rubber bands. Usually causes vascular compromise, thrombosis, necrosis, and eventually sloughing. This is how it works, and I'll show you a quick video of it. These are high-risk varices, grade 2, red whale markings. And hemocystic changes. I need 2 more minutes, sorry. So it's sucked into the device, a rubber band is applied, and here you go. Okay. Endoloops, usually these are placed prior to removing a big polyp. Usually big polyps come with a big blood supply and they can bleed, so we apply this nylon loop, and it's detachable. We put it at the base of the stalk and then do our polypectomy on the top. These are the temporary tubes that we place in patients. They're having active bleeding that is uncontrolled endoscopically. It's a temporizing tube, Sangstein, Blakemore, or Minnesota tube. Each one has a different characteristic, but the gist of it is intubate the patient, endotracheal intubation, then intubate him with the tube, and then inflate the gastric port of it, and just a small tug, and it causes a pressure tamponade on the bleeding vessels. The nurses have a certain protocol because they have to deflate it so that doesn't cause pressure necrosis, and then this is a temporizing measure until a definitive therapy is done. I'm just going to skim through this. Other options that are not GI related, tips, vascular placement of a metal stent that shunts the hepatic vein with the portal system and decompresses. Tagged RBC scan, that's how it looks like with a positive uptake. It tells you the approximate region of the bleeding, but not the exact site of the bleeding. Usually it's used as initial test, and if it's positive, patients undergo angiography with eventual coiling or embolization of the bleeding vessel. So the bottom line, GI bleed is common, can come with high morbidity and mortality and health cost. Basic principles of resuscitation and management are the same, regardless of the origin. The choice of diagnostics and intervention is guided by history and physical examination, endoscopic findings, individual experience, and local expertise. Special thanks to Henning Gerke for contributing to the video material, and these are my sources, plus some more. Thank you, and if you have any questions, please let me know. All right, no questions?